Bismillah ar-Rahman ar-Rahim. The value of patients' verbal complaints and body language in early detection of acute myocardial infarction. I am Dr. Moustafa Yakoot. The global burden of disease in 2019 study estimated 197 million prevalent cases of ischemic heart disease worldwide. This caused about half of deaths due to cardiovascular disease. While cardiovascular disease remains the first cause of total disease burden with about 14.7% disability adjusted life years share worldwide. While in Egypt, cardiovascular disease caused about a quarter of total disease burden, and Egypt was one of the top 5 countries with the highest rates of age-adjusted ischemic heart disease burden in the world, of which acute myocardial infarction was a major contributor. It is well documented that both mortality and subsequent morbidity of acute ST elevation myocardial infarction drastically decreases with a shorter time from symptoms onset to reperfusion therapy. Hence, it is important to reduce delays not only from the first medical contact, but also from the patient himself or first responders at the first scene. According to the 4th joint universal definition of myocardial infarction, clinical definition of myocardial infarction denotes presence of acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute myocardial ischemia. But for the sake of immediate initiation of reperfusion therapy, it is usual practice to designate patients with the clinical symptoms suggestive of ischemia, plus the ST segment elevation in at least 2 contiguous leads as a STEMI in order to initiate reperfusion strategy. The efforts to promote rapid identification and the treatment of patients with acute myocardial infarction should include good education of patients and the public about the signs and symptoms of acute myocardial infarction and how to access the emergency medical system, 911 in the United States, for example, and 123 in Egypt. Prompt initiation care of patients by the community emergency medical system. Emergency medical system or first medical contact should be well trained in defibrillation and educated about the symptoms of acute myocardial infarction, and timely in less than 10 minutes performing 12 leads ECG and immediate decision to triage STEMI patients to reperfusion capable centers. This was highly emphasized in the latest guidelines for the management of acute ST elevation myocardial infarction, and the maximum target times for reperfusion strategy was set as the less than 120 minutes from the patient contact to the reperfusion strategy start. Ischemic chest discomfort as the patient verbal complaints and his expressive movements, the body language, are the first indicators of the disease. Their careful analysis would offer a reliable tool for early detection and can help to save time and lives. The classic symptoms of acute myocardial infarction is pain or discomfort in the chest. Typically, the pain location is in the sternal region, radiating to the left side of the chest and the neck, and down to the medial side of the forearm and hand. Other areas should be in the jaw, epigastrium, and back. But when the pain is severe, it can be felt even on the right side of the chest and the right arm. The type of pain of cardiac ischemia is characteristically crushing or gripping, squeezing, pressing, or heavy band-like strangling or constricting, aching, or even burning in type. The accompanying symptoms may include diaphoresis, nausea, vomiting, shortness of breath, weakness, restlessness, and apprehension. Compared with that of angina, pain of acute myocardial infarction can last for minutes up to hours and is not relieved by rest or sublingual nitroglycerins. The onset can be related to exercise or emotional stress, and in about 20% of patients, acute myocardial infarction is painless or atypical in presentation, particularly in diabetics, women, and in the elderly. And this necessitates careful judgment. When requested to explain the site and character of chest pain, patients move their hands in such a way to show not only the site, but also the quality of the pain they feel. And this is called the body language. Levine sign, palm sign, moving hand sign, and the arm sign are known body gestures strongly associated with acute myocardial infarction, while pointing sign with 1 or 2 fingers to a limited area on the chest is considered, in a majority of cases, a negative or ruling out sign. Levine sign is a clenched fist to the center of the sternum, conveying the gripping quality of pain and the retrosternal location. While the flat palm sign is a pressing flat hand describing the sensation of crushing heaviness in the anterior chest. The moving hand sign is a tight band-like sensation, may be represented by a movement of the palm surfaces of both hands laterally from the center of the chest. While the arm sign is deliberately touching the left arm with the right hand, referring to the pain radiating to the left arm and shoulder. Objectives of our study. The aim of this study was to analyze the value of the patient's verbal description of his complaints and his expressive movements, the body language, as early diagnostic tools for acute myocardial infarction. Patients and methods. The study included 50 consecutive patients admitted to the hospital with acute chest pain, fulfilling the following eligibility criteria. Inclusion criteria: acute non-traumatic chest pain at presentation and documented diagnosis of acute myocardial infarction by ECG and or positive cardiac enzymes. Exclusion criteria were traumatic, surgical, or other non-ischemic causes of chest pain, undocumented diagnosis or cases for whom the diagnosis of acute myocardial infarction was ruled out, cases with left bundle branch block, and cases who do not accept to participate or sign the informed consent form. Methods, the history. All patients were subjected to the following history taking: thorough history, including the demographic characteristics of the patients, age, sex, etc., and a questionnaire with special emphasis on the patient's description of his pain complaints and body language. It included the type of pain, the site of pain and the referral, the intensity of pain, duration of pain, aggravating and relieving factors. Methods examination. In general, physical examination included the temperature, pulse, blood pressure, neck veins, edema, cyanosis, etc., and the full cardiac examination, including any pulsations, thrills, heart sounds, heart rate, rhythm, cardiac murmurs, gallop, or any arrhythmias. Only those who gave permission to have their photo published were photographed during description of their pain or discomfort in order to illustrate the body language. Methods, investigations. ECG was done promptly upon admission for the presence of definite ECG criteria of STEMI. Erase the ST segments at least 2 mm in at least 2 consecutive leads, and the anatomical diagnosis of acute myocardial infarction according to the leads with raised ST segments. Laboratory investigations included cardiac enzymes, troponin I, CK-MB, LDH, C-reactive protein, and SGOT. Echo Doppler study with measurement of cardiac function, global and regional wall motion, ejection fraction, wall motion abnormality, and scoring were also done. Statistical methods, descriptive and analytical statistical analyses were done to test the significance of any association or correlation between any verbal complaints, body gesture, and the definitive anatomical diagnosis. The quantitative variables were studied using Pearson R correlation t-test or one-way ANOVA, while the nominal variables were studied by cross-tabulation of frequency and chi-square or exact test Spearman correlation tests. Results. These figures show the demographic characteristics. A total of 50 patients, 34 males and 16 females were included. Of mean age, males 53.6, and the mean age for females 57.2. And this is the distribution according to the age group. There was a significant association between the pain location and the site of infarction in ECG. And as we see in this graph, the yellow color denotes the wide anterior chest pain, and this turquoise is referring to the retrosternal and the referred pain. These are more associated with the extensive anterior and anterolateral myocardial infarction, while the epigastric and the referral to the back was more associated with the inferior infarction with chi-square significant test. The mean CK-MB levels were significantly affected by the pain locations and the intensity as independent variables. And as we see here, the highest levels for CK-MB were in the retrosternal and left shoulder and the neck referral pain, or myocardial or left or anterior left myocardial. The mean systolic blood pressure was affected also by pain location as an independent variable. It was lowest in epigastric and highest in retrosternal and referral pain. Burning pain was associated more with epigastric and back location, while the squeezing and compressing pain were associated with the anterior chest location, as we see here in this graph. The ejection fraction decreased as the pain intensity increased, while the CK-MB increased as the pain intensity increased. There was a significant negative correlation between the ejection fraction and CK-MB. These are some photos taken for some patients from our series after taking their permission for publication. The first case is a male, 55 years old, presenting with retrosternal gripping pain and Levine sign, proved by ECG to have anterior ST elevation myocardial infarction. This second patient was 52 years old, presenting with crushing heaviness in the anterior chest, and he referred with a palm sign. His ECG showed anterior lateral or anterolateral STEMI, and this is the leads with ST segment elevation. While this man, 65 years old, with tight band-like sensation, he described it by a lateral movement of the palms of both hands from the center of the chest, and his ECG showed extensive anterior ST elevation myocardial infarction. Here, as we see starting from V2 to V6 and also the AVL. In conclusion, this study demonstrated a strong association between the prolonged typical ischemic chest pain or discomfort and the diagnosis of STEMI, as well as the site of pain described by the patient body language or verbal complaints, and the site of infarction found in ECG. Patients presented with anterior or retrosternal pain with or without radiation to the left shoulder, neck, or jaw were more associated with ECG diagnosis of extensive anterior or anterolateral infarction, while inferior infarction by ECG was commonly associated with epigastric pain or pain in the epigastrium and the back. Our study emphasized the value of thorough history taking and analysis of the patient's symptoms as described by both the verbal complaints and the body language for early detection and triage for cases with acute myocardial infarction, training the medical and paramedical staff to how to take advantage of these data could be of value not only to save time and lives, but also for good decision-making and deployment in the limited resource allocation regions. Thank you very, very much.